So I guess I should start. Welcome everyone who joined the EANS webinar today. We're gonna have talks about neurovascular coupling and changes of neurovascular coupling after traumatic brain injury. Let me introduce my esteemed colleagues here. Professor Eszter Farkas, she's from the University of Szeged, well-known researcher on the field of malfunctional electric activity of the cerebral cortex, and two other colleagues from the United States, from the University of Oklahoma, Dr. Stefano Tarantini and Dr. Andriy Yabluchanskiy. Both of them are involved in research of cerebrovascular changes, both in animal models and in humans. And we thought that we're gonna structure this webinar in that way. I'm going to talk about briefly the known changes of neurovascular coupling after traumatic brain injury. And as you will see, I will end up on a few open questions, especially due to the fact that there's not too much results available regarding this important issue. So after my talk, the upcoming presentations will cover how to approach these questions, especially for future research. So let me start with my presentation. Hope it's not gonna start with my first, yeah. Okay. Is it okay? Can you see it? Right. So I plan to briefly talk about traumatic brain injury and neurovascular coupling. Okay. So this is the neurovascular unit, the schematic picture of the neurovascular unit, which is thought to be responsible for the evoked hemodynamic response adjusted to neuronal activation. And this is how it looks like in real life. This is the scanning electron microscopic picture of it. We didn't do this nice picture. I found it on the internet, but it really shows nicely the super dense network of capillaries and arterioles responsible for increasing cerebral blood flow, regionally adjusted tightly in space and time to neuronal activation of given brain regions. And also a classic figure from a classic paper showing that field potential is really closely correlated with changes in cerebral blood flow, among others, aiming at to increase the metabolic and oxygen demand of the activated neuronal tissue. So just to make a step in the direction of the clinical applications of this response, this is the physiological basis for functional MRI. So basically, synaptic activity is transferred directly or indirectly to capillaries and arterioles, leading to their dilation, thus decreasing resistance, thus increasing blood flow. Just show the likely importance of this response. Among other important functions, neurovascular coupling is central in maintaining normal cognitive function. We performed these experiments more or less 10 years ago, making an animal model in which we inhibited neurovascular responses. In the same time, electric activity remained intact in these animals. We were able to show significant cognitive deficit in these animals, establishing a direct link between neurovascular coupling and and cognitive function. It is known that both severe and mild traumatic brain injury leads to profound cerebrovascular changes, both structurally and functionally. And maybe we should follow this path, this didactic path, to talk about severe and mild TBI, as well as the acute phase after the injury, the subacute phase, and the chronic phase after the injury. I just try to summarize here the vascular changes evoked by traumatic brain injury after the insult, and the red font shows probably the most important aspects regarding neurovascular function. So in the acute phase after severe TBI, spreading depolarization or spreading depolarizations play an important role in the observed impaired or changed neurovascular responses. We can also assess pericyte loss, glutamate excitotoxicity, probably all involved in severe neurovascular dysfunction. And also after mild TBI, spreading depolarizations can be observed, and even structural changes as disruption of the blood-brain barrier and metabolic crisis of the brain tissue mismatch between the need and the supply, all probably involved in neurovascular changes. What is known or has been demonstrated regarding neurovascular responses, certainly after acute severe TBI, it's not that easy to evoke neuronal function related vascular responses, since these patients are comatose. So classic neurovascular responses cannot really be measured in these patients. What we have data about is that both in animal models and in humans, spreading depolarizations evoke abnormal hemodynamic responses. Has been demonstrated recently that the late constrictor response is augmented in traumatic brain injury, probably leading to ischemic injury of cerebral tissue. And also it was shown in humans that even an inverse oligamic response can be observed in response to the depolarization wave, and it can even be observed up to 7 days post-injury. And similarly, after acute mild TBI, in an interesting study, it was shown that direct transcranial stimulation and simultaneous infrared spectroscopic data showed that the near signal declined after mild TBI, even in the acute phase. So what about the subacute phase? We don't really have direct measurements, but as I just summarized it on the previous slides, many aspects of the neurovascular unit, injury of many aspects of the neurovascular unit can be observed, just like damage of the blood-brain barrier, pericyte proliferation, which probably leads to impaired pericyte function, contractile function of the pericytes, astrogliosis, which probably represents dysfunction of the astrocytes, which are really important intermittent cells in the orchestrated neurovascular response. And also vascular reactivity is known to be decreased after traumatic brain injury in the subacute phase, and also in the chronic phase. Severe structural and vascular and the functional vascular changes can be observed. Probably these are the underlying reasons why neurovascular dysfunction becomes more apparent in the subacute and chronic phase after traumatic brain injury. And actually easier to measure because usually conscious patients can respond to various stimuli with neuronal activation. So just to demonstrate that this is probably the case, what I was referring to, I just summarize here two interesting studies. Chronic impairment after mild TBI can be, was observed in patients where an uncoupling between resting state fMRI, connectivity contrast, and regional hemodynamic state was shown in these patients, and also with another approach where metabolic activity was assessed by FDG PET, and arterial spin labeling was used to assess perfusion. There was a mismatch between these two signals in mild TBI patients. Again, these are not studies directly measuring neurovascular response, meaning evoked and controlled electric activity-related hemodynamic changes. So finally, I'd like to talk briefly about our own results about the chronic impairment after severe TBI. We tested whether we can observe impairment of MVC years after severe brain trauma in patients already rehabilitated and neurologically functioning. And we also tested whether this neurovascular impairment is associated with impaired cognitive function. So we studied 33 TBI patients and 21 healthy controls, and assessed neurovascular response by transcranial Doppler ultrasound. Meanwhile, the patients were doing the trail making test. So first we found that significant impairment could be observed in various aspects of cognitive function, executive function, memory, and so on and so forth, compared to the healthy controls. And neurovascular responses were severely impaired. We found even negative hemodynamic responses to neuronal activation in these patients. And importantly, neurovascular coupling and parameters representing cognitive function correlated with each other significantly. Interestingly, impaired neurovascular coupling was associated with the initial severeness of traumatic brain injury, and it also was associated with the time passed since the traumatic event, which makes sense. I guess both make sense. Certainly, the more severe the TBI, the more probably morphological injury could have happened, and also time for restoration probably affects the observable neurovascular response. We don't really have too much data on the mechanisms involved in dysfunctional neurovascular responses, neither in animal models nor in humans, but there are a few pathways probably involved in these dysfunctional responses. Certainly, constrictor and dilator pathways could be responsible. The upregulation of the endothelin-1 production was observed after TBI, which is a potent constrictor, so it could be responsible for the decreased hemodynamic response. Also, a decreased activation of the or decreased function of the nitric oxide pathway. Also, as I mentioned, pericytes are injured, and accordingly, the pericyte regulating pathways, impairment of these pathways can be observed after TBI. Activation of MMPs and the result of blood-brain barrier disruption can also alter the function of the neurovascular unit, since it happens right there where the neurovascular unit is functioning. And the well-known, long time known oxidative stress might play a role, especially due to mitochondrial dysfunction. And as I just mentioned earlier, the astrocyte pericyte communication breakdown might be involved in these responses. Let me turn into future directions, and this is where I'd like to present a few open questions, and certainly, actually, I guess the main aim of my presentation is just to open the question that future research has a lot to do about exact measurements in well-controlled populations, both of animals and humans, how neurovascular coupling is changed after TBI, and also what mechanisms are involved in these impairment. So a few imaging possibilities which could be tested in TBI patients in the future, like the already mentioned functional MRI, or the non-contrast perfusion imaging, also using MRI. Physiological monitoring, the transcranial Doppler seems to be a nice tool to assess neurovascular responses. However, spatial so it can certainly only measure blood flow in larger vessels. So we don't have the possibility to use Doppler to identify regional blood flow. NIRS is another option, and I guess Dr. Yabluchanskiy will talk about it in details. And the coupling between electric activity and hemodynamics could be also studied. The already mentioned EEG NIRS coherence studies. And also biomarkers could show interesting or important results, how to connect injury of given structures of the neurovascular unit to the observed functional responses. So certainly a multimodal approach is needed, combining all these aspects of research to assess neurovascular coupling after traumatic brain injury. And maybe some directions for future research. Longitudinal studies are needed, especially that we have some evidence that, as I just mentioned, NVC is not only acutely impaired or subacutely impaired after TBI, but it can also be, it can be impaired years after trauma, after the traumatic event. We also have to understand the mechanisms, since targeted therapies can only be applied based on those. So we also have to figure out how to restore NVC in these patients, especially that I showed that NVC is probably a major player in cognitive function. Also, what I really think important is that we have to define TBI endotypes, meaning that assessing patients from all these, by all these means, means for assessment, could provide us a tailored, patient-specific features or assessment of what's really going on in their brains, and advanced multimodal biomarker panels can be at help in these efforts. And also not to forget that there's a certain window for neuroplasticity, so probably all these changes and their probable restoration ways can be applied on in a certain range of time. So just in summary, NVC dysfunction is probably central in TBI pathophysiology, both in the acute and chronic phases after the event. Certainly severity matters, so probably impairment of neurovascular coupling is more severe after severe brain trauma, but also can be observed after mild TBI. Also an important feature is that NVC dysfunction outlasts symptoms. So if I can refer to our own results, we were able to observe NVC dysfunction in patients with a so-called intact neurological condition. Probably early intervention is critical. As I just mentioned, there's a certain neuroplasticity window to restore function. And again, a multimodal assessment is needed to understand the underlying mechanisms of neurovascular dysfunction after traumatic brain injury. So thank you so much. This is where I would like to end. And we agreed that we're going to have questions at the beginning of all the 4 presentations. So I'd like to ask Professor Eszter Farkas to give her presentation about electric activity of the injured brain. Thank you.
Thank you very much. All right, I hope that it works and you see my screen. Okay, thank you very much for the invitation and also for this introduction, because I have seen that there are many points where my talk can connect. First, I would like to start with the definition of spreading depolarization, which may not be clear to everyone. Maybe this similarity between neuronal loss of membrane potential and the Mexican wave in a stadium is suitable, because spreading depolarization is the loss of membrane potential of a critical volume of brain tissue, about 1 cubic millimeter, which propagates over gray matter at a low rate, like millimeters per minute rate, and it propagates in the human brain along the gyra, so it covers quite some distance. In rodent models, by creating a closed cranial window preparation, spreading depolarizations can be visualized by loading the tissue with a voltage-sensitive dye, as you can see it here. And in this case, the spreading depolarization event was triggered by potassium chloride experimentally. And you can see a beautiful radiant propagation over brain tissue at a rate of about 3 millimeters per minute. Spreading depolarization is probably a classic brain activity type with neurovascular coupling, but can be recorded from the human brain. It has been possible for about 15 years to record spreading depolarization events from the injured human brain, but the recordings are feasible only with an invasive approach by placing a subdural electrode strip over the injured brain region or in the area near the focus of the injury. In these recordings, you can see spreading depolarizations in an electrocardiogram filtered in DC mode. And the indication of the event is that it appears from contact point to contact point with a certain delay typical for the propagation of the wave. So here you can see several events in this recording. This recording is actually from a subarachnoid hemorrhage patient, but similar recordings are required from TBI patients as well. Below the DC filtered signal, you see the ECOG depression during the propagation of these events. Sometimes they are superimposed on a depressed ECOG, and other times an ECOG, transient ECOG depression propagates together with the wave of spreading depolarization. So in the lower left-hand corner, there are original recordings of a spreading depolarization wave from a single point. It's a negative shift of the DC potential and a coupled cerebral blood flow response, which in this case is a short hyperperfusion followed by a large hyperemic response. In this hypothetical trace, you see the blood flow response to spreading depolarization in the intact brain tissue. And actually, this waveform can be broken down to several components. First, there is a brief early hypoperfusion, followed by a large hyperemic phase, and then a second late hyperemia. And finally, the cerebral blood flow response is concluded by a long-lasting oligemia, long-lasting meaning 30 minutes or even beyond 30 minutes. So blood vessels remain paralyzed after a spreading depolarization for quite some period of time. These components, the four components of the cerebral blood flow response, have different share in the response depending on the tissue the spreading depolarization wave propagates over. And this is a very nice illustration from Chenkayata to show that in the center of injury, the blood flow response is usually negative, meaning that the early hypoperfusion dominates and the hyperemic phase is missing. And as we move out further from the center of the injury, in this case over the ischemic penumbra to healthy tissue, the hypoperfusion becomes smaller, and little by little the hyperemic component of the response increases. And when the spreading depolarization propagates out from the injured site to normal tissue, the hyperemic phase dominates the shape of the cerebral blood flow response. Obviously, when a tissue is hyperperfused, like in ischemic injury, but also in TBI, and a negative cerebral blood flow response is coupled to spreading depolarization, this further decreases blood flow in the tissue at risk of injury, with serious consequences for the survival of the tissue. Here are examples from TBI patients. These are data from the group of Jet Hartings in Cincinnati. This is just an illustration to show that spreading depolarizations are recorded from the injured human brain by these electrode strips. And here we see 3 events propagating from one contact point to the other. And when an optode is positioned next to the electrode strip, then the cerebral blood flow responses can be also recorded. In this case, these are hyperemic responses. And I have another example in which the spreading depolarization waves are coupled by a hypoperfusion response. Moreover, as you can see, each response starts at a lower baseline. So step by step, baseline perfusion is also reduced. And it is thought that this type of cerebral blood flow response coupled to spreading depolarization exacerbates injury and contributes to the progression of secondary injury in the acutely injured human brain. Now the question is what mediators are involved in shaping the cerebral blood flow response to spreading depolarization. And in many of our studies, we focused on prostaglandins. Prostaglandins are produced by phospholipids in the cell membrane. Phospholipase A2 cleaves arachidonic acid from the cell membrane. Arachidonic acid is processed by cyclooxygenases to produce prostaglandin H2, which is further processed by prostaglandin E synthase to produce prostaglandin E2, which is a vasodilator when it binds to EP4 receptors on cerebral vessels. And the outcome of this signaling is vasodilation. Now, in order to test if this chain of signaling is implicated in the shaping of the hyperemic response, we pharmacologically inhibited the cyclooxygenase enzymes and the EP4 receptor to see if we can inhibit the hyperemic component of the blood flow response. This is a blood flow response to spreading depolarization in a normal cortex in the rat. And when the EP4 receptors were blocked, then the amplitude of the hyperemic component, as you can see it here and there, was reduced by half. So this was a very potent intervention to prove that EP4 receptor activation was indeed involved or is indeed involved in the mediation of vasodilation. However, when we blocked cyclooxygenase 1 or 2 enzymes, we could not reduce the amplitude of the hyperemic phase of the blood flow response. And the reason why cyclooxygenase inhibition was not did not achieve reduction of hyperemia could be that from prostaglandin H2 there is another pathway. Prostaglandin H2 can be synthesized by another enzyme, prostaglandin D synthase, and the outcome of this pathway is prostaglandin F2 alpha, which can activate FP receptors on cerebral vessels, and the activation of FP receptors achieves vasoconstriction. So it is possible that by inhibiting cyclooxygenase, we inhibited both pathways and we therefore did not observe any change. So next, we intervened at the level of the FP receptor, and we inhibited the FP receptor to see if we can increase hyperemia amplitude or limit hypoperfusion before the hyperemia. And this is what we got in the ischemic rat brain. The AL8810 is an inhibitor of the FP receptor. And by incubating the cortex with this inhibitor, we could increase the size of hyperemia associated with spreading depolarization, as you can see it quantified here as well. In addition, when the cerebral blood flow response was negative in the ischemic brain tissue, meaning that blood flow reduction was seen rather than hyperemia, the amplitude of this reduction was reduced by the addition of the FP receptor inhibitor. And this is important because it shows that the FP receptor activation is probably involved in the mediation of the hypoperfusion phase preceding hyperemia. So returning to this original figure, our receptor inhibitory results indicate that PGE2, the vasodilator compound, may be implicated in the initiation of the peak hyperemic response in the cerebral blood flow response to spreading depolarization, and PGF2 alpha could probably mediate the first early brief hypoperfusion, but it may be present for a longer period of time to mediate a long-lasting vasoconstrictive tone. And the ratio of these prostaglandin compounds must be important to shape the cerebral blood flow response, either in favor of hyperemia or by accentuating hypoperfusion. Either way, it would be important in injured tissue where the hypoperfusion dominates the shape of the response to allow vasodilation. And to this end, we use the nimodipine. Nimodipine is an FDA-approved drug to alleviate vasoconstriction in subarachnoid hemorrhage, delayed vasoconstriction. And nimodipine is an L-type voltage-gated calcium channel blocker. These calcium channels are present on the cerebrovascular smooth muscle cells. And here are two representative traces to show that in comparison to a normal cerebral blood flow response, the addition of nimodipine increases the amplitude of the hyperemic component, but most importantly, it reduces the amplitude of the first brief hypoperfusion component of the response. Nimodipine is also a promising agent because it has additional effects. Very recent studies explore the possibility that nimodipine can inhibit neuroinflammation in addition to modulating blood flow responses. And indeed, in ex vivo preparations, in live brain slice preparations, and in cell cultures, we could demonstrate that nimodipine mitigates microglial activation, also at the level of morphological and functional phenotype, and also at the transcriptomic level. I would like to conclude by saying that spreading depolarization in acute brain injury, including TBI, is a phenomenon that contributes to secondary injury progression. Actually, in TBI, spreading depolarizations occur up to 2 weeks after the primary impact. It is a biomarker. Spreading depolarization is a biomarker of injury progression. And as our pharmacological studies indicate, spreading depolarizations may be perceived as a therapeutic target if they promote secondary injury progression. Their inhibition is expected to improve outcomes. I would like to acknowledge the research group here in Szeged, Hungary, who contributed to this data. I'm grateful to the funding we receive, and I would like to draw your attention to COSBID and their website. This is a group of enthusiastic clinicians and scientists who dedicate their research focus to spreading depolarizations. You can find important data on this website, and if you are interested, you can also join the annual COSBID meeting to learn about spreading depolarizations. Thank you very much.
Thank you very much, Eszter. It was a really great presentation, and as I mentioned, we can have a few questions at the very end of our presentation. So, please, Stefano, could you start yours?
Yes. Can you see the presentation?
Yep.
Okay, wonderful. Well, thank you so much once again for inviting me to participate in this panel. My focus for this next 15 minutes will be to discuss a little bit more about the animal models that we can use to study neurovascular coupling. And just to reiterate some of the points that were already made by the previous panelists, what neurovascular coupling really is this process that links neuronal activity to the changes in cerebral blood flow. And this is necessary to ensure that the brain gets the energy that it requires. I put a little diagram here showing what is usually done is stimulating the whiskers of the animals because that corresponds to a large area of the barrel cortex. Synaptic activity becomes increased in that area. And if we zoom closer, there is a decrease in available oxygen and nutrients and an increase in reduced hemoglobin. And in turn, this elicits the neurovascular coupling response, which is the resulting in dilation of arteries. This image was already shown by Dr. Tóth, but it's just to reiterate the why this is so important, because the functional and structural integrity of the brain is dependent on these physiological mechanisms. The brain energy demands are high, and there is very little energy reserves. Therefore, this rapid adjustment of flow is necessary to maintain brain health. The previous panelist already elucidated some of the pathologies in humans that are associated with changes in neurovascular coupling. And just to add a little bit onto that, there is a recent evidence showing that also cerebral small vessel disease and metabolic syndrome are associated with that neurovascular uncoupling. In my work, I focus on aging and age-related interventions. And along with the neurovascular coupling or the diminished neurovascular coupling responses, there is an array of other factors that are associated with the age-related cognitive dysfunction. But if we look closely at the neurovascular unit, as it was already shown, the increased glutamatergic signaling happening at the neuronal synapse is often picked up by astrocytes through a calcium wave. The signal is relayed to the cerebral vasculature, where many mediators, among which nitric oxide, 20-HT, and prostaglandins, as we have heard, are involved in the mediation of the vasodilation or relaxation during neurovascular coupling. So to get to how we can model this response in mouse models, about 10 years ago, we were doing this using a laser Doppler fluorometry. This is a probe that is placed above the somatosensory barrel cortex, and during the whisker stimulation, we were able to see these traces. In young animals, we would see an elevation of cerebral blood flow higher compared to the one of an old animal. Another technique that can be used, as shown in this video, is laser speckle contrast imaging. The advantage of this technique in animal models is that we can actually now see the whole brain, the surface of the brain. And during the stimulation of the whiskers, as you can see here, we can see the increase in blood flow, specifically in the whisker barrel cortex. Like it was said, 10 years ago, we have done this study where we inhibited some of those mediators of neurovascular coupling using MSPPOH, LNAME, and indomethacin. By applying this cocktail of inhibitors, we were successful at reducing the neurovascular coupling magnitude of young animals from their healthy amount to a pharmacologically inhibited phenotype that is shown here. What we show is that when we pharmacologically inhibit neurovascular coupling responses in animals, that corresponds also to a deficit in cognition, suggesting the strong association between the two. But not only that, it also suggests that neurovascular coupling is plastic. We can inhibit it, and hopefully where the field is going is to find interventions to restore it in case of pathophysiology. A third and more recent technique that people are now using to measure neurovascular coupling is the functional ultrasound imaging. So this is what the machine looks like. And the unique feature of this imaging device is that by placing an ultrasound probe and ultrasound gel over a mouse that has received a craniotomy and has been replaced with a plastic window, we have now access to the entirety of the brain, going from the cortex to the white matter to the hippocampus to the also thalamic regions. In a study that we recently published, we were able to demonstrate that this technique is not only excellent to look at changes in vascular density across aging, but we can also calculate measurements of cerebral blood flow at rest and during functional hyperemia, as I will show you in a moment. So because this is an ultrasound technique, it is subjective to signal degradation due to the skull thickness. So to avoid this limitation, we replaced the surface parietal bone with a plastic TPX window in all our animals. This is actually a pretty routine surgery now. The animals tolerate it really well, and the animal is a suture back after the bone is removed and replaced with plastic. And after 2 weeks, the animal is comparable to an intact animal. So once we have this window in place and we wait 2 weeks for recovery, we're able to put the animal under the functional ultrasound. We inject these microbubbles. These are FDA approved, basically function as a contrast agent for ultrasound. And where these microbubbles are traveling across the across the mouse brain, they leave traces that correspond to the vascular network. We can use signal processing techniques using ImageJ and MATLAB to extrapolate segmentation and certain features of vascular tortuosity and network. When it comes to the neurovascular coupling, we use a mechanical stimulation, which is elicited by a cotton swab connected to a motor. And when we do that, we're able to see cortical responses on the brain, and we can also reconstruct three-dimensional renderings of the brain, looking at all these planes. And in this illustration, you can see the mouse was stimulated on the right side. So in red, we see the actual neurovascular coupling response on this animal. We're also able to superimpose it to the visible cerebrovascular structure underneath it and put this in the context of the whole mouse brain. Another important element is that neurovascular coupling can also be done not only with the whisking of the whiskers, which elicits a response on the somatosensory cortex, which is shown here in the 3D rendering and here in the coronal section. But if we stimulate a different region, for example, the hindpaw, we can find a response to a different brain region. And here I'm showing the region that corresponds to the hindpaw in the cortex. In another study that we have recently published, we then compare laser speckle contrast imaging quality to functional ultrasound imaging in the neurovascular coupling quantification. We also compare the time factor after the implantation of the cranial window with plastic. So we demonstrated acutely it's not a good idea to measure neurovascular coupling since the brain is still recovering from the surgery. But after 2 weeks with a chronic cranial window, we are able to detect a significant difference using the laser speckle contrast imaging. And that magnitude is actually higher when we use the functional ultrasound, suggesting that there is a higher sensitivity to the measurement using the functional ultrasound. Additionally, we're able, like I showed before, to have a 3D rendering of the magnitude of the response. If the laser speckle contrast imaging only gives us a bird's eye view from above, where we can locate the response, with the functional ultrasound, we can actually compare coronal, sagittal, and actually also transverse sections to see completely the response in the mouse brain. So what are some interventions? At the beginning, I mentioned that we are interested in the plasticity and the recovery of the neurovascular coupling with aging. So in this recent study, we have shown that when we do a train of stimulations, so it's a 7 neurovascular coupling stimulation using our automatic stimulator, we can elicit a robust response in the young animals. This response is diminished in the old animals, and it's about a halfway decrease. But if the old animals were exposed to 6 months of intermittent fasting, actually the response was much higher. And this is shown here on the plots on the right, showing the average cerebral blood flow increase, the maximal cerebral blood flow peak value, and also what the average traces look like, showing that the old animals after the intermittent fasting regimen were the best performers. Another interesting set of data that we have from our mouse studies is using IFED diet. Here we're showing that in a cohort of animals that were exposed to a high-fat diet across 6 months of time, we see a robust time-dependent decrease in neurovascular coupling as a function of the time they've been exposed to the high-fat diet. And when we administer senolytic agents such as ganciclovir and ABT, ganciclovir is a genetic encoded trigger in this mouse that selectively eliminates P16 positive cells. And when we do that, we see that the neurovascular coupling response is significantly improved. Since I mentioned that the neurovascular coupling responses are tightly connected to cognition, in the same animals, we measured cognitive function using the radial arm water maze. And we see that those animals that had diminished neurovascular coupling responses in exposure to IFED diet also showed decreased cognitive function. So as far as my conclusion for the animal component, we know that aging is profoundly impairing neurovascular coupling and reducing stimulus-evoked cerebral blood flow and delayed vascular responses. We believe now that functional ultrasound imaging is providing a sensitive, high-resolution platform to quantify neurovascular coupling deficits across brain regions. And old mice, in addition, are also showing other cerebrovascular phenotypes with aging, such as macrovascular refraction, endothelial dysfunction, and impaired vascular activity, and all could be contributing factors to decreased neurovascular coupling. Neurovascular coupling impairments are correlated with cognitive deficits, particularly spatial learning and memory, and task dependent on white matter integrity and processing speed. Some of our data that I showed suggested that neurovascular coupling is a modifiable physiological target, and the interventions such as diet, genetic intervention, and pharmacological interventions can also restore the vascular responsiveness. And generally in the field, mouse models are accepted to study mechanistic dissection of these components, such as the components of the neurovascular unit, including endothelial, glia, and neuronal contributions to the neurovascular coupling breakdown. And lastly, neurovascular coupling metrics can provide a powerful translational biomarker, and hopefully this seminar will help everyone to understand that it's also a potential bridge between preclinical and clinical vascular function in human aging and other age-related pathologies. So this is the conclusion of my part.
Thank you very much. We got one question for you, but as I mentioned, we're gonna turn on the questions at the end. So I'd like to ask Dr. Yabluchanskiy to talk about measurement of NVC in humans. Thank you.
Great. Can you tell me, do you see my full screen? All right. So thank you very much. It's my pleasure to share with you some of the work that we do in my laboratory in human participants. There are several approaches that people utilize these days to assess neurovascular coupling in clinical setting. And the gold standard approaches include functional magnetic resonance imaging, PET scan, and others. As can be seen on these examples, the one on the left, this is the fMRI image from a participant engaged in the language task. You can really see and assess this regional change in hemodynamic responses. This is the bold signal, as well as you can utilize PET scanning. And this is an example of activation of certain brain regions in the participant who is here involved in the meditative prayer. The only difficulty with this type of methodologies is the the price tag, at least in the United States of America, one scan of fMRI imaging will cost you about $800, and then if you have multiple visits for one participant in the clinical study, that price tag really ramps up. This is just another image to show that fMRI imaging can be used in aging setting to assess age-related change in neurovascular coupling responses. Another complication of these approaches with fMRI is the paradigm to evoke neurovascular coupling response. Most of the time, it involves visual stimulation, but the checkerboard presentation has been done in this particular study, where you can see the activation of the occipital region. And finally, one more obstacle in utilizing these methodologies, fMRI and PET, at least in our population, in aging population, is that not everybody can tolerate long periods of time spent in the magnet, including our older participants. As well, there are some contraindications that would prevent participants going into the MRI imaging. So we utilize several approaches. One of them is functional near-infrared spectroscopy. I'll be showing you the setup that we use in the next slide, but there are several paradigms you can use with FNIRS methodology. We use cognitive stimulation, but you're not really limited to it. You can use motor stimulation, visual stimulation, and so on. One of the cognitive stimulation paradigms we use is the cognitive NBAC task, whereby participant is presented with a sequence of change in letters, and participant is requested to react every single time they recognize a certain pattern. For example, the one-back task, participant will need to click every single time when the letter repeats itself in a sequence, and this task gets progressively harder. Participant need to click the mouse button every time they see the letter repeats itself 2 letters back in that sequence. This is a 2-back task is already challenging for some participants, especially if you talk about older individuals. They become very vocal and they start complaining about the difficulty of the task. But you can utilize this paradigm also to assess their cognitive responses. For example, in healthy adults and healthy younger and older individuals in Oklahoma in particular, you can already see that on one-back task, there is already a separation in the accuracy, in the performance on this cognitive task. And this discrepancy becomes even bigger and with a more challenging task, the 2-back task. So while our participants are performing this cognitive task, we assess the hemodynamic response in their brain. We utilize the FNIRS methodology. It utilizes the near-infrared light, and what it allows you to measure, the distribution of oxygenated and deoxygenated blood, so oxyhemoglobin and reduced hemoglobin. The problem with this methodology, though, is that you're really limited to the penetration depths of the infrared light. The light does penetrate the skull, the skin, the skull, the subarachnoid space, and gets into the cortex, but you're really limited to about 0.5 centimeter depth in the cortical tissues. But when you assess neurovascular coupling response, and for that we utilize several methodologies. These are heavily coding-intensive processes. We utilize several approaches. There are commercially available approaches. There are approaches developed in our laboratory. We use MATLAB and Python-based coding. Analysis will result in producing the heat maps of, as shown in this example. This is the top view of a hat with the nose pointing upwards. This is the hemodynamic response during the cognitive stimulation in a young individual. You can see there is a robust increase in hemodynamic response in this prefrontal cortex region. And when you compare that to the older adult, you will see that this neurovascular coupling response is significantly impaired. And when you correlate the beta values, the magnitude of neurovascular coupling response in younger and older individuals versus the cognitive performance on that very cognitive task, you will see that in older adults, which shown here with the red line, there is a nice correlation, which is not observable right now in the younger individuals. We explain this by the fact that this task itself may not be challenging enough in young individuals to evoke this association. But in older adults, you can see it. The task we implement right now, it's about 2 minutes long task, and you can also evaluate the dynamic change of neurovascular coupling response over time during performance of this cognitive task. And you can see that in young individuals, the neurovascular coupling response builds up pretty high during the first 30 seconds, and then it plateaus out for the duration of the paradigm. In older adults, the situation is slightly different. There is activation happening in the first 30 seconds, and then it dies out and dies off for the duration, for the remainder of the task. Now, when you approach hemodynamic assessments of hemodynamic neurovascular coupling response, if you take individuals with known pathology, for example, peripheral arterial disease, those individuals that have a known endothelial dysfunction, right? This is, if you consider this being an animal model of endothelial dysfunction, you just need to find people who have it. You can assess the contribution of neurovascular coupling response and cognitive deficits in these people. This figure on the left demonstrates the difference between participants with peripheral arterial disease and control participants. In other words, this demonstrates that participants with peripheral arterial disease have a significantly impaired neurovascular coupling response. And now that translates to cognitive deficits that are observed in these participants. When you take participants with known cognitive pathologies, such as mild cognitive impairment, this is already a prodromal stage to dementia. And when you assess their neurovascular coupling response, again, versus the control participants, you will see the similar situation where the dorsolateral prefrontal cortex particularly involved. And this figure demonstrates that in participants with mild cognitive impairment, there is a impairment of neurovascular coupling response in the regions corresponding to the cognitive paradigm that we implement in here. And finally, what we use with one of the projects we use with this methodology is in people with chronic mild TBI, chronic mild traumatic brain injury. There is knowledge that the cognitive deficits they are present in participants with chronic mild TBI. And if you look at the magnitude of neurovascular coupling responses in participants, in MTBI participants with preserved cognition and those with impaired cognition, you will see that neurovascular coupling response is significantly impaired. But what is interesting, in those with preserved cognitive function, you already see an impairment of neurovascular coupling response, which suggests that these participants may be on a trajectory of further impairment of their cognitive abilities and may be a good place, a good cohort for interventional studies. Now, FNIRS assesses this hemodynamic response, but the beauty of this methodology is that you can combine it with others, such as EEG studies. I will not be showing you data today, but this is what we're doing these days in our participants. You can simultaneously assess the neuronal component and hemodynamic component in our study participants using the multimodal FNIRS EEG system. Another approach that we utilize in our laboratory is the transcranial Doppler. Now, this is a slightly different approach. You assess blood flow velocities in the deeper, larger arteries. This is an example of the change in blood flow velocities on the left and on the right side, measured through the acoustic window in the middle superior artery of younger individuals during the less challenging and more challenging 1 and 2 back tasks. You can appreciate that there is increase in the hemodynamic response in the blood flow velocities that supply the prefrontal cortex during the more challenging task. And in older individuals, it also has been shown using this methodology that there is association between cognitive performance and neurovascular coupling response measured using the transcranial Doppler. And finally, another methodology we utilize in our laboratory is by assessing the dynamic retinal vessel, by assessing the dynamic changes in retinal vessels. Now, one can consider the eye the window to the brain. This is essentially a piece of central nervous system that sits outside of the cranium. You can visualize the optic nerve, and you can visualize the vessels, the arterioles and venules. Unlike TCD or FNUS, you can actually see changes with your own eyes. So this system is equipped, essentially what it is, it's a fundoscope that allows us to take pictures of the retina. But it is also equipped with the camera, which allows us in real time to assess the changes in diameter of retinal arterioles and venules. In this particular case, we stimulate photoreceptors, which are neuron-like cells, by the flickering light. And what you will be able to see is that during the start of the flicker, there's a change in diameter. The arterioles increase as well as venules increase in their diameter. And then they return to their normal diameter after the flicker is finished. We can see that there is a difference between younger and older individuals in the assessed by neurovascular coupling responses in retinal arterioles. When you try to combine that with cognitive abilities, trying to build association between neurovascular coupling response measured in the eye with cognitive function, if you take our participants, both young and old individuals, and you rank them on their performance from high to low, on cognitive performance, and one of the tasks, this is particular, was the delayed matching to sample task. And then if you do interquartile comparisons, basically quartile of those that scored the highest and quartile that scored the lowest, you can already see here, because these are people, this is the heterogeneous population. You can see that majority among those who scored the highest, majority are young individuals, with one participant being an older adult. And majority in those that scored the lowest in our cognitive task, majority are older individuals with a couple of young individuals. But if you take these two quartiles and you look at the neurovascular coupling responses measured in retinal arterioles, you can see that those with high scores in cognitive performance, they had an increased neurovascular coupling response compared to those with low cognitive performance. And finally, this will be the last figure to show that multimodal assessment. We also have done this study where we assessed simultaneously the change in blood flow velocities in the posterior cerebral artery that supplies the visual cortex during the dynamic retinal vessel analysis. And we do see this is in the preparation right now for publication. We can see that although these are two different basins, but we already see that there is a very comparable change in magnitude and time in neurovascular coupling response measured in the posterior cerebral artery, as well as in retinal arterial and venules. And with this, I would like to thank you for your time and attention.
Thank you very much, Andriy. We have literally a few questions. One is for Dr. Tarantini, which is, after surgery on mice, is it possible to cause brain damage or alter brain function during normal day-to-day handling or care of these animals who got this plastic stuff on their skull?
Yeah, so because it's a hard plastic, and after we secure it to the skull, we also close the skin. The animals are actually indiscernible from their healthy counterparts. So they go about their functions just as good as an age-matched control mouse, and we have done those validations. So the surgery is very reliable. If the person has some specific questions, I can point them to our recent publication or my email address.
And if you were thinking about a protocol for brain trauma on these animals, would you perform trauma, then prepare this window, or can the trauma apply through this window?
Yeah, this is a great question. This is something that we actually been actively trying to answer ourselves. So I guess depending on the type of trauma, it would be worth to try a few things. But my feeling, my suspicion is that by applying the window, we would just need to tweak the type of impact that needs to be delivered, the type of energy, because the mechanical properties of the plastic are very different from the one of the bone. But I think it would be feasible with the plastic.
Thank you. So there's another question from Joseph Diduro, which is, if neurologic functions function is reduced in TBI, why is NCV hard to measure when there are significant vascular compromise? So I guess I can answer that because it relates to my presentation. What I meant was that in comatose patients where a neuronal response cannot really be evoked, for example, by a cognitive task, it is really hard to measure regional blood flow responses to neuronal activation. But this question leads to another question I wanted to ask Professor Farkas, that what about the neuronal activity in deeper brain structures? What sort of possibilities do we have, not only to measure neuronal activity on the brain surface or in upper cortical areas, but in deeper brain structures? Do we have any possibilities?
I'm not aware of possibilities in humans. In rodents, just like Stefano Tarantini, we used functional ultrasound, and you can see deep into the subcortical gray matter, but we do not see signs of spreading depolarization in the subcortical gray together with the cortex. On the other hand, the striatum is also vulnerable. So if you, when we run, for example, live brain slice preparation experiments on coronal brain slices at the level of the striatum, and we deprive the slice of oxygen and glucose, oftentimes we see spreading depolarizations in the striatum as well, in addition to the cortex. Sometimes we work with the hippocampal coronal slices. For some reason, the hippocampus does not produce spreading depolarizations as often as the cortex or the striatum.
Thanks. So there's another question. What about NCV impairment after repetitive MTBI? I would say probably it's more severe than after one single MTBI, which was shown in those studies I referred to. I also have a question to Andriy. So among all of these approaches on humans, which one would you choose, or would you choose a combination of them, or what's the idea about in which situation which approach is the best, or how would you describe this?
I think among all the possible approaches that exist today, the combinatory approach is the best, of course. Would be the FNIRS with EEG, gives you the more round picture of hemodynamic and neuronal components of neurovascular coupling response, of course. And I personally like the retinal assessments because something you can visualize with your own eyes. There's a difference when you rely on data analysis and modeling and the coding to do the work for you. FNIRS EEG, they're cheap, and this is speaking about the sample size and the power analysis, the data that comes from human participants. I think it's more environmentally friendly and more importantly also portable. You can do it outside. You can do it at home setting. You can do, and then you're not limited by the paradigms, right? So you can have a motor paradigms, visual paradigms. You can assess while people walking, etc. So if I were to choose today, the combination of FNIRS EEG would be the goal. This is what we do.
Thanks. So thank you very much. If I can summarize and conclude, especially for the audience, I'm really grateful, first of all, for the speakers, because what we really wanted to present here is that neurovascular function, neurovascular coupling is probably severely impaired in TBI patients, also in MTBI patients, probably in repetitive MTBI patients as well. And seemingly, especially the presentations of the measuring approaches, seemingly they didn't really talk about TBI, but our purpose was to show how to proceed in future research on this field. And I'm really happy that you guys also talked about the effect of aging, because it also point out and makes one note that once we're gonna run longitudinal and prospective studies in TBI patients, especially with regard of neurovascular coupling, we have to focus on comorbidities, and among them, probably one of the most important one, aging, and the effect of aging on neurovascular coupling, because this is going to be the baseline to which we are comparing the effect of brain trauma. So thanks again for signing up for this webinar, and also again for the presenters for their great and excellent talks. Thank you very much.
Thank you very much.
Thanks.
Thank you.
Thank you, Péter, for organizing this.
All right. So I don't know how we proceed with the conclusion of this.
We can just end it now if you want.
Okay. All right. Thank you.
Have a good night, everyone. Good evening.
Thank you very much again. See you
Bye.
guys.
Thank
Bye.
you. Bye.